I also wanted to go over some fat mass diseases that are linked with obesity. And one of the most common fat mass diseases that we see in obesity is something called osteoarthritis, or OA. Osteoarthritis is sometimes like colloquially referred to as the wear and tear on the joints. So it's often seen in the knee joint because that's kind of the primary load-bearing joint of the body, and osteoarthritis really means like inflammation of the joints and the bones. Okay, so we often see unhealthy or degenerative articular cartilage that can also promote tears in the bones that are associated with that joint too. Okay, and what sucks about osteoarthritis is, let's say you have obesity and you develop osteoarthritis. Well, osteoarthritis can promote obesity too, because if your knees hurt all the time, exercising, moving your body at all, or even standing to make food can be compromised. So it's something that like we know obesity promotes, but it's also part of what makes obesity so complex to treat too. Okay, so we do believe it's the weight of the body that's promoting osteoarthritis, but also arthritis, inflammation of the joints. So unsurprisingly, there might also be a linkage between that dysregulated adipokine secretion pattern and inflammation around not just the knee joint, but other joints in the body too. Another thing that is common in individuals with obesity is something called obstructive sleep apnea, which basically means that individuals with obesity or just with sleep apnea, when they sleep, they stop breathing. They might stop breathing for 10 seconds, 20 seconds, a minute, or more in some cases. And we believe that it is more of an anatomical situation when it comes to obesity and sleep apnea, where that accumulation of adipose tissue, that higher fat mass, is leading to an occlusion of that upper respiratory pathway. So it's just really like the pathway is blocked, so there's no air that can move through it. Okay. What we often see with sleep apnea is it can have a number of cardiovascular effects because it can promote hypoxia and higher levels of carbon dioxide as well, which also has metabolic effects too. The good news about sleep apnea associated with obesity is that we can typically improve it if individuals lose weight, and we can also manage it if they don't. Okay, so for instance, you should watch this video because this gives you, I'll show this in class, gives you a little video of someone with chronic sleep apnea showing just how long they can go without breathing. But I also wanted to show you these CPAP machines, these continuous positive airway pressure machines, and they've gotten smaller over the years. And it's not just individuals with obesity that might need them. These people with sleep apnea in general might need these, but people wear these devices when they sleep. And what these CPAP machines do is they promote an airflow into that respiratory pathway to keep this open. Okay, so we can again have gas exchange, and so people don't stop breathing when they sleep. Okay. Some other obesity-associated comorbidities that are more on the fat mass disease side include GERD, gastroesophageal reflux disorder. Individuals with obesity, they are more likely to have compromised lower esophageal sphincter closing, probably because they're receiving more volume into their stomach. Because of the impaired closing or just larger volume of the stomach due to larger food intake, that there's a higher risk that stomach contents can spill up into the esophagus, and those stomach contents are acidic in nature due to hydrochloric acid that's secreted in the stomach, which can damage the esophageal passageway, which in some cases can lead to a precancerous state known as Barrett's esophagus. So this can happen not just in obesity, but is more likely in obesity as well. And again, weight loss does help. Urinary incontinence also increases in obesity. So this is when an individual has a harder time keeping their bladder, not peeing themselves. And part of the reason, this is more anatomical in nature again, although there's probably physiological reasons too, but as far as the anatomical reasons, if you just have more fat mass, especially more visceral mass, pushing down on your bladder, that increases the chance that you're going to feel like you need to pee more often. Okay, and again, increased abdominal volume and pressure can promote other changes like hernias as well. Abdominal associated hernias typically occur when a part of the small intestine basically comes out through maybe an opening in the connective tissue that's typically holding things in place. So hernias can be quite painful and they typically require treatment, but again, just a note here that they are more likely in obesity. Okay. So at the end of this unit, hopefully you realize how many different comorbidities are associated with obesity for a number of reasons. Often one of the main reasons is this increase in pro-inflammatory adipokine secretion pattern. There are other things that are linking adiposity and more of those sick fat diseases, such as perhaps increased lipid production and dyslipidemia, changes in insulin sensitivity and insulin resistance. But also remember that adiposity also has these effects on just kind of the mechanics of the body. So that can affect our joints, our intra-abdominal pressure, and have a number of kind of more anatomical effects on the body. But I really just scratched the surface in this unit because there's so much and we have so much to cover in this course, because I just wanted to give you a brief overview of the comorbidities associated with obesity. Okay. So like I said, obesity comorbidities are typically divided into two groups: the adiposopathies, or sick fat disease, which are these diseases associated with obesity more due to the dysregulated adipokine secretion pattern and the pro-inflammatory state that promotes, but also the mechanical stress of carrying that extra weight can promote structural, anatomical changes in the body that can have a number of impacts on just our ability to be in our body and to move in our body. And in addition to all these physical complications of obesity, recall that obesity also affects quality of life because of the potential social and mental consequences as well. So, take care and be kind when you are working with individuals with obesity, because there's a number of complications that this disease can have on the body and on the mind and on our relationships, and that might affect a lot of different aspects of that person's well-being. But we also want to look at people as individuals and not just see them as their diseases, which is something we're going to focus more on in the end of this course when we start looking at obesity treatments and managements. Okay, so hope you learned a lot about obesity comorbidities, and I'll see you in class next week.